Is head-up tilt test obsolete in current scenario? The short answer is no, it is not entirely obsolete, but its role has significantly narrowed in contemporary clinical practice. The head-up tilt test has transitioned from being a routine first-line diagnostic tool for unexplained syncope to a highly specific niche investigation. Its decline in routine use is largely due to its notoriously poor reproducibility, variable sensitivity and specificity, and the rise of more reliable long-term monitoring technologies. Here is a breakdown of where HUT stands in the current diagnostic landscape based on contemporary guidelines. Situations where HUT is no longer recommended. Classic vasovagal syncope. If the clinical history is classic for vasovagal syncope, example triggered by pain, standing or emotion with typical prodromes, diagnosing reflex syncope is clinical. A tilt test is redundant and unnecessary. For assessing treatment efficacy, HUT is highly discouraged for evaluating whether a pharmacological therapy for vasovagal syncope is working. The test lacks the reproducibility required to confidently determine if a negative second test is due to the drug or simply test variability. Unexplained syncope with high arrhythmic risk. In patients with structural heart disease or abnormal baseline ECGs, where an arrhythmic cause is strongly suspected, HUT is bypassed in favor of electrophysiological studies or prolonged monitoring. The current clinical niche where HUT still adds value. Despite its limitations, HUT remains a class 2A or 2B recommendation in specific challenging scenarios. Differentiating syncope from psychogenic pseudosyncope. This is currently one of the most valuable uses of the tilt test. In patients with frequent swooning or falls without true loss of consciousness, observing the patient during a provoked episode, often while recording video and concurrent EEG, can definitively diagnose psychogenic pseudosyncope if hemodynamics remain perfectly stable during the event. Confirming autonomic failure. HUT is highly useful for diagnosing delayed orthostatic hypotension, postural orthostatic tachycardia syndrome, or unmasking underlying autonomic neuropathy such as in Parkinson's disease or multiple system atrophy when active standing tests are borderline or inconclusive. Atypical reflex syncope. When a patient has unexplained syncope that is suspected to be reflex in nature but lacks the classic prodrome, HUT can help confirm susceptibility to vasovagal reflexes. This is particularly relevant in older adults where the presentation might be atypical. Occupational or high-risk screening. For patients in high-risk professions like pilots, commercial drivers, heavy machinery operators, demonstrating a negative HUT might be required for occupational clearance after an isolated, unexplained syncopal event. The shift to prolonged monitoring. The biggest driver rendering HUT less relevant is the advent of the implantable loop recorder or insertable cardiac monitor. The paradigm has shifted from provoking an episode in an artificial lab setting to capturing the spontaneous clinical event in the real world. ILRs provide absolute symptom rhythm correlation, which HUT often fails to do. If a patient has recurrent severe unexplained syncope, modern pathways heavily favor early ILR implantation over an exhaustive non-diagnostic autonomic testing battery.